Hi, everyone. This is David Cora. I'm Senior Clinical Advisor for Cure Blindness. I'm here today to just share with you some of the updates on the new outreach form. This is an orientation for physicians on how to best use the form. So let me just share my screen here. And here we go. Okay, very good. So this is the new form. I'll just get to the part that is the most important for the physicians. We've redone the exam and the surgical portion to make it simpler and to make more sense to us as ophthalmologists. So looking at the exam, as you know, it's a requirement to do a slit lamp exam. In case that we're unable to do a slit lamp exam, there's space here to choose whether it's slit lamp or torch exam. It's also required to do a dilated exam. And so if dilation is done, yes, and the time of dilation, which helps you track when the patient is due to come back in for their dilated exam. In the future, we anticipate that the patients will be able to have their pupils checked by the allied personnel. So the afferent pupillary defect is actually up here right under intraocular pressure. But if you need to check the afferent defect, it is up here. Yes or no for a right afferent defect or a left afferent defect. The patient would be dilated and then in the future, hopefully come to you already dilated. So we have the slit lamp exam now simplified somewhat into cornea, the grade of the cataract, lens comorbidities, and the retina. This is fairly self-explanatory. If everything is normal, it will be these boxes on the left-hand column that get checked so that very clearly visually you can look at the form and see if one of these are not checked, then there will be a problem over here. If there's a corneal axial opacity, please indicate that as it can affect postoperative vision. Cataract grade, we will revamp this a little bit, but the basic issue is there should only be one box that is checked. The opacity of the lens, whether it's nuclear or posterior capsular or cortical, either it's mild, moderate, dense, or white. So please select one of those. If they have an intraocular lens or a posterior capsular opacity, one of those can be selected. In terms of lens comorbidities, if there are any, please clearly indicate this as it helps the operating surgeon to know whether there's pseudoexfoliation, zonular loss, whether the lens is hypermature, whether there's a posterior polar cataract, or if it is brunescent. For the retina, there's space to put the cup to disc ratio, nerve pallor, macular scar, and in the case of a more severe cataract, if there's no view or a hazy view, and there's also space to indicate a retinal detachment. Now, here in the notes, there's space to write any notes that you need to write. And there's some check boxes that are easy to just check off if there's trauma, history of trauma, a small pupil, posterior synechii, history of trachoma that's affecting the current findings. If there's a glaucoma bleb, which is critically important for the surgical planning, if there's a history of glaucoma or amblyopia. And this one is significantly important if there's any nasolacrimal duct reflux. So for a period of time, we did have sac syringing on there as a way of ensuring that the nasolacrimal system was clear. At this point, we've decided to go simply with pressure on the nasolacrimal sac to see if there's any reflux of mucopurulent material through the system. If there is, then it is up to the physician to decide what to do in terms of surgical planning. So maybe a course of antibiotics, maybe return for some future exam, maybe sac syringing. What is important is if you check, which you should, the nasolacrimal sac for reflux, and it is negative, it is helpful to put a line through this, indicating that it was checked and the finding was negative. There's not enough space here to write yes or no for all of these things, but for significant negative findings, it's always helpful to put a line through it, which indicates that it was checked and not found. So every patient, I always put no pseudoexfoliation, no zonular loss, and no nasolacrimal sac reflux or no nasolacrimal reflux just by putting the line through those. Now, this is a critical piece of information. Please take the time to finish this. Could post-op vision be limited due to comorbidities listed above? And this is basically to give us guidance as to what to expect for post-operative vision. So an axial corneal opacity, a retinal detachment, a macular scar, any of those things could affect post-operative vision. In that case, please mark the box yes, and if it is not, please mark it no. There's a new section here for the examining physician to make the surgical plan. First, select the approach. Is it a superior SICS or a temporal SICS? I think in general, superior is our default, but in the case of a glaucoma bleb, we need to clearly indicate that it is temporal. In the case of high against the rule astigmatism, the patient is benefited by a temporal SICS. And so now a new field here with the biometry is that they're instructed to, instead of recording biometry in millimeters, to record it in diopters so that we can easily see how many diopters of astigmatism are present, and to record the axis. So that will guide you in selecting that. And then this is important, is to indicate the level of complexity. The quality of the results are determined by matching the complexity of the surgery with the skill level of the surgeon. So we have white cataract with no other problem. That's the lowest level of complexity, perfect for resident cases. Those will be the cases going to the residents. The immature cataracts, which are the ones that are not white, or if there's brunescence, posterior synechii, some pseudoexfoliation, history of glaucoma, or a small pupil, those can go to our early experienced surgeons. And then cases of trauma, corneal opacity, zonular loss, posterior polar, hypermature, and with glaucoma blebs are the most complex and should go to senior surgeons. And then, of course, we have those monocular patients, which are level 4 complexity, which will be assigned to the most experienced surgeons with the lowest complication rates. And that is basically it for the exam. There, in the surgical part, one important thing to note, it is very important for us to capture surgical complications. This is simplified now in that there's a list of complications. There should be a list in the operating room that corresponds to this, that you can simply look at that list or that poster and tell the staff number 1, which means no complications, or number 4, hyphema. So they can, instead of trying to interpret the language, simply will circle a number. And if you need to leave any additional intraoperative notes, that space is here. And then just briefly on the post-op exam, day number 1, the exam findings, the ones that are critical to note, a slit lamp exam is required. Please indicate if it is done. And any of these findings here can simply be noted here by the number. So if there's a central air bubble, indicate number 1. If there's corneal edema, simply indicate number 2. That will help greatly with the legibility and with data recording. So that's it. And if there's additional surgery planned, you can also indicate in the notes number 1, cortical washout, number 2, hyphema washout, whatever that corresponding number is. Sorry, that would go here with additional surgery. So that's it. Thank you very much. And look forward to getting your feedback. We will make adjustments to this as the feedback comes. So thank you so much.